Sound check, sound check. Hi, folks. Professor Gulliford here. Let's go ahead and do a screen share. We're going to share the sound and the video, and we're going to talk about acid-base balance all the way out. That's a big.
Sometimes there's a pretty significant difference between the two.
I guess I've been saying every chapter is important. Well, this one is too.
Because if the patient forces it
knowing
out,
particularly
they
how
may have
to
some
read an
bronchospasm that
ABG
shows up,
is a very valuable
and they have
skill.
smaller
And most of our colleagues, including some of the doctors, really don't know how to do this. So they rely on us to do it. The nurses definitely don't.
Summarizing the lung volumes,
they're counting on us to be the experts on this.
Every respiratory
acids and bases in the body is what we're going to really talk about here.
Volume the patient can
given a clinical case,
the
identify the
maximum volume the
acid-base
patient can exhale,
status.
and then
We're
residual
talking about
volume is the trapped
acidosis
air
or alkalosis,
remaining
and it
after
can be
the
either
exhalation. There's
respiratory
always
or
some trapped
metabolic.
air. Now, here's
So
an
you'll
interesting thing for
discuss
you
the
to,
role of the respiratory
to
system
figure
in
out.
maintaining
In a normal
acid-base
patient,
balance,
that's
but
just
also
1,000,
the
1,200,
kidneys
something like
have a
that.
very key
But
aspect
in an emphysema
here
patient,
in
that
balancing
might be 2,000,
the
3,000
pH,
or more,
maintaining
because they have so much
homeostasis, we say.
trapped air.
So we've
from
got
the
respiratory
damage to their
acidosis,
lung
respiratory
tissue.
alkalosis, metabolic
So the residual
acidosis,
volume tells us
and
a
metabolic
lot
acidosis,
about
and
the
metabolic
patient who may
alkalosis.
have emphysema.
You'll also come to understand base excess or deficit.
This is how much we breathe every minute.
And the differences between arterial and venous. Sometimes these days we get by with a venous blood gas because our oximeters are now so good that we count on them to tell us about the patient's oxygen.
18 times a minute.
And then we'll go over the normal values for all those things: CO2, pH, CO2, O2.
So there you go.
Bicarb.
Minute volume is just how much they're breathing every minute. There's a test.
A lot of us don't really use base excess very much. I should mention that to you. The bicarb tells us what we need about that, but
what we
still need to understand what it
have
is.
the patient breathe as hard and fast as they could for
Getting
12
a sip
to 15
of coffee.
seconds.
pH is a measure of the acidic
how much
or
air they can
alkaline
move in and out of their lungs
nature of any solution, including the blood.
And then we would multiply,
and it's really
by
the hydrogen ion concentration is what we're talking about.
If it was 15 seconds.
So
but let me tell you
hydrogen ion is inversely proportional to the hydroxide ions. And the higher the hydrogen ion, the more acidic the solution, which would mean the lower the pH. I think you guys know that a lower pH means a more acidic. 7.4 is the exact normal arterial pH that we're shooting for, the range 735 to 745. When the pH is too high or too low, then all kinds of bad things happen, and chemical process is not going as well as they should. So here we go. A high pH is alkalemia, and a high pH is also called alkalosis. Alkalosis is the term we use more in medicine. A low pH is acidemia. And the condition that we describe is acidosis. Normal pH is 7.4, but few patients are exactly normal. They're somewhere between 7.35 and 7.45. And the venous is a little different, but really pretty similar. That's why we sometimes we'll go ahead and use the venous blood just as a simple way to estimate this. Newborns, it's interesting, really, quite different.
And the main things we get
up to 3 days of age, 731 to 747. But then after 3 days,
which is how much the patient
things kind of get where they're going to be for the rest of that child's life. 735 to 745.
Of the FEV1 to the FVC.
So those are important numbers. 735 to 745.
Measures that we get.
Homeostasis. Here we go. So much of what we do in medicine is try to help the patient achieve homeostasis, and it's chemical buffering, the respiratory system, and the renal system.
So you might
We're going to go into that in much detail here over the next 45 minutes or so. But it's chemical buffering, respiratory system, renal systems.
Okay.
And your respiratory system can change very quickly to adapt for homeostasis, but the kidneys take a little longer, maybe 24 hours or even a couple days to fully have their effect. And that effect is what we call compensation. Compensation. Here we go. This is interesting. This is the pH of various things
But Dr. Tom
lemon
Petty,
juice,
University of Denver,
vinegar, very acidic,
describes
very
this
acidic.
as a broad
Mean
mountain,
pH of the Adirondack lakes. That's interesting.
That's the shape that it should be.
About
now, if the patient has
pure rain 5.7,
we
distilled water 7
in that broad
mountain. Because water is pH
and
7,
if they have
and baking soda
the mountain
way out
goes
there
pretty much
over
straight
8.
up and straight down. We call that the witch's hat.
So your blood is
like
735 to 745.
You would see
acids and bases are electrolytes. So electrolyte is any molecule that can release ions. Most acids contain a hydrogen ion that can be released, and that's called dissociation.
It's better.
More hydrogen ions means lower pH.
So there we go.
Acids are classified as either strong acids or weak acids on that basis.
We can get a peak flow assessment as well as the
strong acid dissociates. Some examples are hydrochloric acid,
every part of the cycle,
hydroiodic acid. Not familiar with that one.
And there's a
nitric acid and sulfuric acid. Those are all strong acids. Some weak acids that we actually deal with are vinegar. Would be a great example.
We measure flow.
Citric acid,
0.5 seconds, 1 second,
hydrochloric
2 seconds,
acid,
3
and
seconds.
uric acid.
But by far,
and you can test the pH with litmus paper. You may have done that in a science class at some point.
What we base
but you use the litmus paper to determine the approximate pH
which is the FEF 2575. And the thing
fatty acids are molecules made up of hydrocarbon chains with
and the thing about that
carboxylic acid group attached to the end. Fatty acids and their associated derivatives are primary components of lipids.
So everything else might be within normal limits, but the mid-flow.
And then fatty acids can be either saturated or unsaturated. We think that part of the American health problem is way too much saturated fat in the diet.
Forced inspiratory flow.
When you're having that double cheeseburger with bacon,
and there's nothing on boards about it,
and French fries that were fried, that's a lot of saturated fat going in.
Shows a peak flow,
so we're trying, as a society, to be a little smarter on what we consume.
And the mid flow.
But if you study nations that don't consume all that saturated fat, they have much less heart disease. Also, much less cancer and fewer strokes.
Measure the flow at any point in the curve.
Essential fatty acids, we've got to have those, and they particularly come in the omega-6 and omega-3
the number one test.
Omega-3s are largely in
and
fish,
it's often done
and when we eat more fish or when we supplement omega-3s, we really help our body.
Patient a treatment
tremendous
with albuterol.
Advantage to have more omega-3s. If you're not going to eat a lot of fish, then what you got to do is supplement that omega-3. It comes in the capsule.
Then we say
kind of a large,
FEV1 improve,
slightly yellow capsule. I do it every day because I do like fish, but I'm not going to eat enough of it. So I do supplement that every day. Molecules, chemical bases, or chemical opposites of acids, they can also be weak or strong. I bet they're going to give us some examples here. Yep.
If they go up by
potassium hydroxide, sodium hydroxide, lithium hydroxide. And then some weak bases would be ammonia.
Most PFT machines.
So in the household, we've got at least one example of an acid, which would be vinegar, and one example of a base, which would be ammonia,
things are
commonly used for cleaning.
There are differences among the
body has 3 chemical buffering systems.
For example, I would like
you to think carbonic acid buffer system. Carbonic acid. We've got the phosphate buffer system. And we've got a protein buffer system.
Hispanic or
and they all have an important role. They all kind of work together
Oriental or anything else
to keep our pH in a safe range.
They have longer legs,
your pH doesn't have to get very far out of whack for it to be dangerous. A pH of 7.0 is very dangerous. A pH of 7.6 is also very dangerous. So
the Caucasian will
the
have
extracellular fluid and
capacity,
intracellular fluid involved in these buffering systems. Intracellular more the phosphate and protein, and extracellular more the bicarb and protein. And they all work in different ways. Amino acid buffer works on all proteins, hemoglobin buffering system, and the
So why
plasma
do we do
protein
this testing? Well,
buffering
severity
system.
of lung
They all work together.
dysfunction,
You don't need to
change in
know a
lung
great
function
deal
over
of
time.
detail
We have
about that,
lots
to
of
be
patients
honest with
that
you.
have
You
to have
just
a
need to know
PFT
that
done every 90
there are
days.
systems in
We're
place
tracking
to
them.
buffer our blood and keep it
Progression
in a
in
safe
lung
range.
function following
Carbonic
treatment such
acid
as
buffer system
chemotherapy,
maintains a balance
environmental
between bicarb
exposure.
and carbonic
There's certain
acid.
jobs that have to have a PFT every year.
And then that shows you the formula. You don't need that formula. You'll never actually do this formula.
Example of that.
But bicarb plus sodium hydroxide
tests.
gives you,
I once had
or rather, carbonic acid plus sodium hydroxide gives you bicarb and water.
Honda of America, and there were 12,000 employees.
Sodium bicarbonate plus hydrochloric acid gives you
on an annual basis.
Carbonic acid
we
plus
kept,
sodium chloride,
people
salt.
busy.
So all things that we deal with on a day-to-day basis
here we
in
go.
that buffering system.
Other types of PFTs include nitrogen
It's a pretty
washout,
slick system
dilution,
that nature's come up with.
plethysmography.
Normal ratio
Those
between
determine-
bicarb
those
and
three
carbonic acid is 21.
determine
So 20
the
times more
residual
bicarb
volume that we've
ions
talked about
than
several
carbonic
times.
acid molecules.
We also do diffusion capacity testing.
This is all
and
going
we
on
do
without us
bronchial
having any
challenge
awareness
testing. That's
of it.
kind of an interesting thing.
The whole
let's say you think the patient has
acid-base
asthma, but
balance
their PFT
system
is normal.
is
We have them
calculated
breathe
by the
methacholine.
Henderson-Hasselbalch
Let me just add
equation.
that here.
It would be useful for you to know
definitely need that.
just the name,
Methacholine.
Henderson-Hasselbalch equation. That's what's going on in the blood gas analyzer when it is giving you the results of your blood
That's
gas.
one you've heard of.
But actually doing it, you'll never actually do this. It's the Henderson-Hasselbalch equation.
That seems cruel, but it's how we make the diagnosis of asthma. If they respond,
carbon dioxide level can be used interchangeably with carbonic acid.
There's an
because the partial pressure of CO2 can be easily measured. What we do in blood gases is we pick the one we can measure most easily, and we use that. And then we do the math to come up with the ones that are harder to measure.
So the
one we can measure is CO2.
The problem
you'll see that on every single blood gas that you get here.
A few people.
So the calculation
testing,
is pH is pKa plus the log of bicarb over PCO2 times 0.3. Now that one is 0.3. The one for oxygen is 0.003. And the reason I've mentioned that repeatedly is they have a sneaky question on the board exam where they give you the formula, but they put 0.03 instead of 0.003. So you need to recognize that the 0.03 one is wrong. And it's the 0.003 one that is correct. In some cases, they don't have you do the math on boards. What they do is just have you recognize the formula. Bicarb is 22 to 26, so 24 would be perfect.
There's a multiple breath.
And CO2 is 40. The range is 35 to 45, so 40 would be perfect. And then this formula shows you the relationship, which you will not need to calculate. This is all done by the blood gas analyzer, and it does not show up on boards either. But you do need those normals. Bicarb 24 and CO2 is 40.
Residual capacity. That's the one.
Henderson-Hasselbalch equation is what does this for us.
Where we've got
really quite remarkable that it can do all this for us. Some of the values that we actually report in a blood gas are not measured; they're calculated using this formula.
Now you don't have to
mention the
actually
name
do
again.
that math.
Henderson-Hasselbalch
in the pulmonary
equation.
function computer. When we started,
there's a way that you can arrange it to solve for CO2,
ourselves. We had
and a way that you can arrange it to solve for bicarb.
The flow volume loop.
You won't have to do those.
Wow.
You won't have to do those calculations.
Helium dilution is
you
the
should
next
know what
one.
the
Henderson-Hasselbalch
is.
Where you have the patient
So let's look
helium.
at a patient with a pH of
talk funny
7.29. That's low. That's going to be acidosis. O2 is 88. That's normal. CO2 43. That's normal. Bicarb a little low.
That's to happen. Now,
acidosis. So we've got a metabolic acidosis.
But the
and the saturation is
concentration is usually about 10%.
So I bet we're going to use those numbers here
because it's diluted.
Yep.
And that tells us
so we want to alter the pH to get back into a normal range. 7.38 would be a good example of that. And this allows us to actually calculate how to do that.
C1 times V1 equals C2
Pretty
times
cool.
V2. You won't have to actually do that.
This shows the actual
Nobody's
math.
seen that on boards. But it's the initial concentration, the final
correcting
concentration,
the pH
and the volume.
From a somewhat low pH to one that's within normal limits. And it tells us where we would need the CO2 to be
to get to the volume.
Pretty cool.
You won't have to do that calculation. Never. All modern PFT
using the same scenario, but let's look at it with bicarb.
Body plethysmography
is a fascinating test. You'll never have to do this. Don't
affectionately call it the
apprehensive about it. But
this
just shows you that you can actually come up with the correction.
Call it transparent. Box
to get to that desired pH.
And I might mention once in a
while, we
while
don't do this clinically, and I kind of wonder why we don't do it more. Probably because we've learned from experience how to do it without doing the actual math.
But they're so claustrophobic.
You'll see what I mean as you're adjusting ventilators.
We put the patient in there. We have them.
We pretty much go
against resistance. We have them pant against
5 at a time
and measure their residual
2 at a time
volume.
on the rate.
So it is the most accurate
and just
way.
make the
now,
adjustments.
That is something that we've seen on boards
because we know what's going to happen. It's predictable.
Which is the most accurate way for determining.
All right, phosphate buffering maintains a homeostasis inside the cells.
And it is the body
Phosphate's present in both the intracellular and extracellular fluids.
And there we go. There's a picture of it right now.
The intracellular concentration of phosphate is higher than extracellular,
pattern,
making phosphate a more
asthma
potent
looks a little different.
Buffer.
COPD looks a lot different.
And this is what's actually happening in the phosphate buffer system.
Volumes.
You'll never have to do that calculation, but that shows you how it's being
diffusion
done
capacity
with hydrochloric acid and producing salt
capillary membrane.
And
we actually use
phosphoric
a very
acid.
small amount of carbon monoxide. Yes, I said
this is the sodium monohydrogen phosphate.
The gas that can
plus
kill you if
sodium
you get
hydroxide
up to 20 parts per million.
Results in a weak base
we're using such a tiny
water.
amount that the patient is
so that's
not harmed.
buffering. That is all that buffering is
we just measure
making changes to
across the alveolar
achieve
membrane.
Closer to normal pH.
It is the single breath
protein
test
buffering system is primarily active in the plasma and cells.
Take a big deep breath in. They breathe.
All three
mixture,
are important.
Which is
amino acids have the ability
to
contain negatively charged carboxyl group, that's COOH,
over 10 seconds.
And this means that proteins can function as hydrogen ions, depleters, or donors. And when they deplete or donate hydrogen ions, they are changing the pH. These adjustments are made subtly and slowly over time. We're totally unaware that this is happening, but it's happening all the time.
Then there's
amino
a lot
groups,
of
R groups,
to the
carboxyl
alveoli,
groups.
and they will diffuse less.
That's the
because
protein
of all that
buffering
damage.
system.
There's just less surface.
Most important protein buffer is
challenge
hemoglobin,
is the one
most assuredly.
A little bit ago.
Hemoglobin just absolutely essential for human life and health. Mostly because of its ability to carry oxygen, but also it carries carbon dioxide.
Find out.
It by the way, binds with oxygen and carbon dioxide at different places on the molecule.
We always, if we do,
so carbon dioxide can be removed in this way
there's
as the patient is exhaling.
But we always give them.
And there's a picture of it all happening.
Afterward to bring them out of
CO2 is let's start with the lungs.
Important.
Oxygen binds to hemoglobin.
All right.
You can see it's attaching.
It takes a 20%
heme groups.
If there's a 20%
oxygen is released from hemoglobin to the tissues.
That patient does
CO2 binds to hemoglobin, and hemoglobin takes it back.
Exhaled nitric
the
oxide.
carbamino hemoglobin mechanism. Hemoglobin's busy. It's very busy getting oxygen to your tissues, and then very busy again taking carbon dioxide back.
Then it tells us that patient
and it does that at different places on the molecule.
But if
I think it's
coming down,
remarkable that one molecule
can
have both of those capabilities.
Eosinophilic
Volatile acids are easily converted into gaseous form.
Will bring
and the volatile acid that we're most interested in is carbonic acid. That's what allows us to
do some
get
tests
the
of
carbon
the respiratory
dioxide
muscles,
through the blood
like the
and
MIP,
out
maximal inspiratory
through the lungs.
pressure, and MEP.
Central and peripheral chemoreceptors are
end-minute
monitoring this all the time.
We want to know how strong the
They're
respiratory
located at several places in your body, and they're constantly
key
saying,
number
are we in balance? Are we too acidic? Are we too
It needs to be at least
alkaline?
minus 20
And
centimeters
it all
of water
happens with
for the
signals
patient to
going back
breathe
to the medulla.
effectively on
Remember,
their
we mentioned the
own.
medulla
If their MIP
as the
is
area of
less
the
than
brain
minus
that's most
20,
involved
I can't get the zero to go in there.
in respiration.
There we go.
This is the
patient will need
the respiratory system ability to respond within 1 to 3 minutes
MIP is probably
of a change in
minus 90
CO2.
or minus 100.
Remarkable. The kidneys much slower, a day or even a couple days.
20,
but the respiratory system within a few minutes
the MEP
can
MEP
produce a change in ventilation. Let's say the patient
90, something like that.
just had a major surgery. They're
40,
given a narcotic for pain.
Positive 40.
And their respiration is slowed because of that. Well, your peripheral chemoreceptors and your central chemoreceptors will realize that very quickly, within a few minutes, and make adjustments because of it.
In 6 minutes.
Just remarkable that nature does all this for
us. For pulmonary rehab, sometimes they can only
There's the formula showing CO2 and water coming together for carbonic acid, and then the hydrogen ion and the bicarb. That equation is essentially going on all the time in your body.
A long way. Healthy young people can walk.
The lungs alter the rate and depth of respiration as needed, and they do it within minutes.
Then they are
as the pH of the blood declines, the blood becomes more acidic or acidotic, and the respiratory system responds by increasing rate and depth.
So we'll
and
get
the reverse happens if the pH increases.
This afternoon. I'm doing this on Tuesday morning. Cardiopulmonary exercise testing is where we actually put the patient
very effective,
on a treadmill
absolutely
or
essential,
exercise
but
bike,
slow.
and then do a lot of the same tests that we've
got all this
do at
blood
rest.
going to the kidneys,
so that's pretty interesting.
producing urine,
in that
and they are making decisions. The kidneys are making decisions about how much to excrete and how much of each thing to excrete.
All of that.
There's a little expression you're going to hear
and it will
at
tell
the
us
hospital.
a lot
I'll
about
mention
the
it to you now.
Fitness,
air goes in and out.
General cardiopulmonary
blood goes
health.
round and round. You are
Normal
not
oxygen
smarter
consumption,
than the kidneys, so don't try
from
to
a normal
be.
level of 250
And you cannot fix
to as
stupid.
much as 3,500.
That is what
really
that's what we say in medicine,
Maybe
and
as
it's
much as
all
even
true.
5,000.
If we had to actually
think about your
do
body's ability
consciously what the
to do
kidneys
that,
are doing every day,
rest, we only
we would be overwhelmed.
consume
but we
about
don't have to.
250. But
The
if
kidneys,
running from a
meaning
bear,
nature,
it's one of my professors
just takes
always
care
said,
of it.
If you're running from a bear,
So about
you're
20%
probably
of your
gonna get up to
cardiac
about
output goes through the
5,000.
kidneys every minute, and they are adjusting all
Increase
the
in
time
heart rate,
to that
the athlete's
changing
heart may be
composition of the
40%
blood.
larger than
It happens in a place
non-athletes,
called
and
Bowman's
it's not
capsule,
the thickness,
Bowman's space
it's
specifically.
dilated in a good way.
But this is
because
where
the heart
the
is
decisions
pumping
are
more
made
each time.
as to what's
Each time
going
it
to be
pumps in a well-trained
excreted
athlete,
and
it's
absorbed,
pumping more.
or what
That's
we're
called the
holding on
stroke
to.
volume.
These decisions are made for hydrogen,
And this
potassium,
goes into a level of
creatinine,
detail
drugs.
that you really don't need.
I want to
respiratory
mention something.
therapist.
We've learned
Sleep studies are
recently,
fascinating.
just over the last few years,
Somnograms.
that
We're
ibuprofen,
measuring
a very
lot of
common
different
medication,
things, but let me give you some
and if it's
terms
used
that
in a
definitely show up
reasonable
on
way,
boards here. There is
pretty
a
safe, but
nasal
too much
thermistor.
ibuprofen can really damage your
nasal
kidneys
thermistor,
because it is
at the
completely
patient's nose,
excreted
which
by
is
the kidneys.
measuring airflow.
So let's not use too much of that. Too much Tylenol definitely harms the
that tells
liver.
us is there
Too
actual
much
air moving in and out of the patient's
ibuprofen
lungs.
is really
There's also
hard
a
on
thing
your
called a
kidneys.
strain gauge.
So just caution
that
with
is
that.
around
Never
the
more than
patient's
the
chest,
amount
their
that
lower
is shown
chest.
on the label.
And that is measuring
So we get
respiratory
urine flowing
efforts.
out of the ureters,
So
and
what we
what's
sometimes see
excreted
is that there
in
are
that,
respiratory
what's
efforts
excreted
going
in
on,
that
but no
is
airflow
determining
going on.
the
and
pH.
that would be obstructive
There's a
sleep
picture of the
apnea.
actual
Patient
tubule.
needs CPAP,
See if
or
I can blow that
needs
up a
some
little
kind of
bit.
treatment for the obstructive sleep
At
apnea.
the
We're also
glomerulus,
looking at
distal
electrical
tubular,
activity
tubule,
by EMG.
peritubular capillaries, a collecting duct,
during that test. Also measuring the oxygen
the
saturation,
loop of Henle.
of course.
At the
What we
bottom,
do
they don't have it
sometimes is
labeled.
put the
I don't know
patient
why,
on
but it's
CPAP.
called the loop
Once
of
we see
Henle,
they're
and that's where a lot of our
put them on
diuretic
CPAP
medications
and see
actually
if we
have
can
their
fix it.
effect.
I think
Lasix
this
is one
the
of those.
smartest
You've
thing
probably
that's
heard
come
of
along
Lasix,
for a while.
which is
What we used to do is do a
furosemide.
sleep study,
But
see the
nonetheless,
obstruction,
all that
send it
process
to the doctor. The doctor
is
would say, "Okay, yeah, they're definitely obstructed."
making
so
adjustments
let's do another
day to day.
sleep study. With CPAP
Not as
and
fast
see
as
if
the
that
lung, but
fixes it.
nonetheless making
Well,
those
today,
adjustments.
they trust the
Non-volatile
respiratory
acids
therapist
sometimes called metabolic acids or fixed acids,
put the patient on CPAP,
are involved with the kidneys.
Help.
And also, some examples include lactic acid. You've probably heard of that. When you had a hard workout and you're sore the next day, it's lactic acid that made that happen. Phosphoric, sulfuric, acetoacetic, and beta-hydroxybutyric.
But the patient
those
is
are
still
all
snoring
acids,
loudly.
and the kidneys are responsible for removing them.
What should you do? Well, what you should do is
kidneys also filter bicarbonate.
You want to increase
about
it
85 to 90% of it is resorbed.
And part
that's a key thing that the kidneys do is decide how much
there's also a thing called multiple
should
sleep
be
latency
excreted
interesting. It's
and how much should be resorbed. That's really the key function of the kidney buffering system.
They may actually be dealing with a narcolepsy type problem.
Lungs and kidneys are two primary systems that respond to alterations in pH.
Let's say with driving a car.
And they work together. It's a beautiful kind of a partnership
test is another thing
to
we do.
keep the patient in balance.
Sleepiness.
The 4 types of disturbances, we're going to do some practice together for interpreting this: respiratory acidosis, respiratory alkalosis, metabolic acidosis,
peak expiratory flow,
and metabolic
how much the patient can exhale with their
respiratory acidosis. That's where the CO2 is too high.
This is very helpful for asthmatics.
So CO2 rises.
Asthmatics should have their own.
That is an acid condition.
Their own peak flow
CO2 is an
so
acid.
They can check this.
I like to tell students that you know that CO2 is acid because when you open a can of Coca-Cola,
right there,
you hear that. That's the CO2, and it is so acid in that can of Coca-Cola that you can actually use it to clean your battery terminals.
But she blows hard.
So it is acid. CO2 is acid. When that goes up, it causes respiratory acidosis.
Let me give you some numbers that
if the CO2 is low, meaning like the patient is hyperventilating, that is going to be a reduction in acid. And when there's a reduction in acid, that's an alkalosis situation. This makes more sense when we do some examples.
Something like that. If the
metabolic acidosis occurs when the bicarb levels decrease, causing the pH to drop.
And
that is a classic case of
because
diabetes.
Peak flow is less
when
than
the patient is a diabetic
asthma
ketoacidosis case, it is because the bicarb levels have dropped very substantially.
Spirometry is not really a
metabolic alkalosis is probably the least common of these.
What we do is
but when it happens,
10 breaths per hour.
One situation where it can happen is overdose of bicarb, overdose of, say, Mylanta or Malox or any of those solutions that are antacids. But this is when the bicarb levels
pneumonia,
cause the pH to rise. And there is a mixed state. We don't see this a lot, but sometimes both the respiratory system and the kidneys go the same direction. So that's called a mixed or sometimes combined.
Thing you need to know. If you don't get the patient's best effort,
we'll see at your hospitals where you train which term do they use. But this is where two disturbances happen simultaneously.
Is we would like to stop.
I had a particular asthmatic patient who was also diabetic. And they wound up with a combined acidosis because of that.
Because once in a while, a patient
combined acidosis,
and they wound up in the ER. So,
and there it is. That's a little description of the primary acid-base disorders: respiratory acidosis, increased CO2, decreased pH; respiratory alkalosis, decreased CO2, increased pH; metabolic acidosis, decreased bicarb or an increase in hydrogen ions and decrease in pH. And then metabolic alkalosis, just the opposite: decrease in hydrogen ions, increase in bicarb, increase in pH. Good little summary there.
Issue with the body box.
So ABGs give us all these numbers.
It's not worth fighting.
And there is a number for base excess. It's calculated as the non-respiratory portion of the pH change. So it's basically telling us how much of the pH change is not due to respiration.
Obstructive disorders?
Normally, we draw blood gases from the radial artery. That's the first preference. That's the artery on the thumb side of the wrist. We cannot
cystic
draw from the
fibrosis.
ulnar artery. That's a question students ask me sometimes because
Bronchitis.
there are tendons that lay over the ulnar
Asthma.
artery. So that's not a good option. If the radial cannot be used, then brachial is where we go next. That's the one in the sort of middle of your arm. It's the one that they check your blood pressure. That's the one they're listening to, and they check your blood pressure.
That is the
and you can do femoral
obstructive disease
artery.
Right,
that's usually done during codes.
About
the femoral artery is in the groin.
First
and if the patient's blood pressure is very low, that may be the only one that we can actually get.
It's going to be less than
VBGs. We do beat VBGs, and we also do capillary gases. The numbers are a little different, but they provide useful numbers, particularly for the pH and the bicarb. They are, useful for that and easier to get. That shows you that's the reason we do them. For infants, we do a lot of CBGs, capillary blood gases. We warm up the baby's heel.
And also
do a heel stick. For VBGs in adults, it's just blood that we've already got. We're going to run a lot of tests on that blood every day, so we've already got the blood, so we'll do it that way. What you can't trust is the oxygen on either one of those. And then here we go. Look at these ABGs all in one place.
It's restricted.
VBGs all in one place. Newborns,
lung disease,
and then adults, capillary blood gases. We really don't see capillary gases for adults.
In Western America,
just for newborns. But it's cool to have all those numbers in one place where you can refer to them.
That we all inhale.
How to interpret blood gases? I actually have a card that I've created that I think does a better job of telling you how to interpret these. Many students. Actually, 149 students in my program have used that little card. So I'm going to go over that. That'll be like a separate recording rather than do this, because I think they make it more complicated than it needs to be. So what we'll do is just skip down here.
Very useful graphic,
and I'll go over my own card, which I think
PFTs,
we
do them every day.
These compensatory mechanisms are all very important. The respiratory system and renal system work together to achieve normal balance.
Can't even imagine.
Respiratory system compensates
We're going to use them to
for metabolic disturbances, and the kidneys compensate for respiratory disturbances.
Basic PFTs
it can be a respiratory acidosis, respiratory alkalosis, metabolic acidosis, or
really means getting the
metabolic
RV
acidosis.
That adds up
and
to the
we can,
FRC.
get the arterial blood gas itself,
helium dilution,
but sometimes we use the VBG or CBG
we also do diffusion capacity,
because it's a good enough estimate for the pH and the bicarb.
And respiratory muscle.
Here are the normal ranges, which we've actually showed you several times now. But pH 7.35 to 7.45, CO2 35 to 45. That's handy that it's so similar to the pH. Bicarb 22 to 26. That 24 is just wrong. It's 22 to 26. So I'll fix that there. Base excess -2 to +2. Oxygen 80 to 100, and saturation 95 to 100.
6-minute walks, sleep studies,
CBGs. Really the significant difference is the oxygen. Everything else is very close. But with the oxygen being only 60 to 70, we cannot use a CBG
later today
for assessing oxygen. The rest of it
is also very important.
And that's that. Okay, I'll be doing a recording for you on the ABG interpretation. That probably will happen tomorrow, but then we'll actually practice that when we get together next week.